Hello everyone, welcome back to another episode, PT Forensics. This is episode number 3, and today we will be talking about lumbar disc herniations, very common injury, condition, disorder, whatever you want to call it, very commonly seen in the physical therapy world. And today, Corey and I will be going over 2 research articles that discuss this point, two kind of different viewpoints of it, which should be good, get a whole encompassing thought about the topic. But let's just go right into it. So Corey's going to start us off with the patient case for the day.
Sounds good, Dave. This patient case, again, I think one that's pretty commonly seen in an outpatient orthopedic scenario. The patient's a 38-year-old male, and he's being seen as a direct access patient, right? So Dave and I work in Connecticut. We're able to see some patients directly without necessarily having seen a primary care physician first. So he's being seen for low back pain with radicular pain into his left leg. The pain's worsened when he tries to bend over, tries to get up from a chair, if he sits too long at his desk. And initially he reported he had a lot of tingling into his posterior thigh and calf. And it was pretty constant at first, but now this is intermittent only. It kind of just comes and goes. He feels a little tingle, moves around, and it kind of goes away. But the pain at this point can be kind of a shot of pain or like a shock-like pain into the posterior thigh. And then after that, it typically hangs around as like a deep ache. He's had pain for 2 weeks. He's tried Advil with some temporary relief, but he's very fearful he needs back surgery because his father actually had a similar issue. And his father ended up having back surgery and had some trouble afterwards. So right now he's really questioning, like, does he need an MRI? Right? So he's seen your direct access. He doesn't know what to do at this point. He says, do I need an MRI? Am I going to have surgery? And that's kind of where we started with him. So the article I had decided to look at was at how well we are as physical therapists, how good we are at determining whether or not we're dealing with a patient with a radicular back problem, right? So is this someone who has a herniated disc that's potentially causing compression onto a nerve root? So I looked up into our PubMed database and determined that we actually have a Cochrane review that looked at this sort of thing. So it's the Cochrane Back and Neck Group, and they first published this review in 2010. It's called Physical Examination for Lumbar Radiculopathy Due to Disc Herniation in Patients with Low Back Pain. Now, if you've ever read a Cochrane article, they're like massive, right, Dave?
Oh my God.
Massive. They have tons of information on their methodology. I'm not going to delve into all that right now. I think that's a little bit beyond this. But the goal of their article basically was they were going to determine the value of different physical examination tests done alone or done in combination to diagnose a symptomatic herniated disc. They included 16 cohort studies and 3 case controls. And the biggest problem with all these Cochrane reviews, of course, at the end, it's always, more research is needed, the end of every Cochrane review. But so the biggest limitation, I think, that we'll find in this article is that almost every single study was done, the reference that they used was a diagnosis of a disc herniation on surgery, right? So almost all of these cases, all of these studies that were included ended up surgical patients. So generalizability is tough with that. There was one study that had a primary care population, and again, you can try to generalize that. It's only 1 out of 19 studies. We'll kind of go over that. So the reference test they used initially was MRI or CT scan, myelography, or most commonly was findings during surgery. All right, so they evaluate 11 different tests. And before we get into the specific tests, I just want to give a quick little recap on sensitivity and specificity. If you're someone who's been out of school a little while, maybe isn't totally familiar with these terms, I want to kind of make it seem a little bit simpler to you. So in diagnostic tests, you get 2 results, right? Positive or negative. Either you test positive for a condition or you test negative. But there's not any perfect tests out there. So most or all tests are going to have some level of false positives or false negatives, right? So you're going to have people who have the condition who test negative or people who don't have the condition who test positive. A test of sensitivity is basically giving you information about the rate of false negatives. So a test that's highly sensitive is going to have a low rate of false negatives. Basically, these are good screening tests, right? So these are tests where if you get a negative result, you're pretty confident that that person doesn't have the diagnosis, sorry. On the other hand, specificity is the rate of false positives. So a highly specific test will have very few false positives. Again, on the other end of that, you can trust that if you have a highly specific test, your positive findings are a true positive. So.
Oh, Corey, by the way, you gotta drop the the mnemonic reminder for them.
Oh, of
yes,
course.
very important.
Again, all those words might sound great here, but the best way to remember it, I think, if you're in a pinch and you can't quite remember what they stand for, is the spin and the snout, right?
I like it. Yeah, that's good. Yeah.
With the extra little syllable in there. So the spin there is a specific test, SP. A positive test rules it in, right? So spin, SPPIN. Specific test, positive test rules it in. A snout test is going to be a sensitive test, SN. A negative test is going to help you rule out. So snout, spin and snout.
There it is. Perfect. That's all you need to remember.
Nice friendly reminder. All right. So delving into some of these physical exam tests, most of them should sound pretty familiar. There were a couple I had never heard of, but maybe I had just never heard the formal name and test that I've done before. First one was the straight leg raise test, or they also refer to it as Lasag's test. I think I'm pronouncing that correctly. Yep. Basically, the difference between the straight leg raise and the Lasag's test was that in the second one, they used a level of ankle dorsiflexion during the test. Right, so straight leg raise test was just lifting the leg up in knee extension, seeing if you reproduce pain. Lasag's test was they were adding in some dorsiflexion to that test. But again, a big issue, and they pick apart this nicely in the Cochrane view, is that really the test methods were not well documented in any of the studies. So they could have been doing a number of different things in these studies, and it was hard for them to pull out what exactly was being done. But in either way, they did calculations of specificity and sensitivity. Specificity for the straight leg raise test was kind of all over the map, but generally the sensitivities were higher. So the sensitivities were like 0.91 to 0.94. So with that, again, just as a standalone test, if you're using the straight leg raise test or Lasag's test with some dorsiflexion to rule out lumbar radiculopathy, you can be pretty confident that if they test negative, they probably don't have a radicular problem. Similarly, they looked at the cross straight leg raise test, right? So that's similar to the straight leg raise test where the knee is extended and the leg's passively brought up in supine. But this is actually done on the asymptomatic side. So for our patient case, he had a left-sided problem. The cross straight leg raise test would be done on the right side. So the pooled estimates for sensitivity of the cross straight leg raise test were 0.28, so not such a sensitive test, but the specificity was much higher, it's 0.9. So it's kind of nice. You can kind of use those together. A negative straight leg raise test being a valuable test for you in your decision making, and a positive cross straight leg raise was found to be a valuable test. They actually look at just a test called the scoliosis test, which was basically just a visual inspection, and they determine whether or not you had scoliosis. I'd never used that, to be honest, in a lumbar radiculopathy. Obviously just general observation, but necessarily as a diagnostic test. Dave, have you used that before?
I have not. No, this is the first time I'm hearing about it used for this condition, at least.
Same for me, and I think it's probably a good reason because it actually was found to have poor sensitivity and specificity. So
there you go.
Scoliosis, while it may be valuable, and one of the things we talked about in school a lot was that it's actually arguably could or could not be the cause of low back pain a lot of times, or not necessarily the cause, but associated with low back pain. It's actually not found to be a very valuable test when looking to diagnose lumbar radiculopathy. So some of the other tests they went into, which I thought was really interesting because, we're actually starting to look at sensitivity and specificity of our general neuro exam. So we looked at things like paresis and muscle weakness. If somebody has the presence of, a weak anterior tibialis or great toe extensors, Is that pretty diagnostically valuable? So it was looked at in 7 different studies, and one of those studies had that primary care population. But the majority of these studies found limited utility for this test in isolation, again, remember. The study that was done in a primary care setting found that the presence of paresis of a muscle or muscle weakness to have high specificity. Right, so again, that was only one test, but that was the only one done in a primary care population. But again, I think we'll see as we get towards the end of this that it does become a more valuable test when it's used in combination with other things. As a standalone, maybe not so much, but who's going to do just one test to rule something in or out? Mm-hmm. Muscle wasting was also looked at, and they basically just used calf circumference for that, which is an arguable way to measure that. But they looked at 3 different studies, and it had a lot of heterogeneity in those studies. Basically, they concluded just looking at muscle wasting by using calf circumference was not a very valuable test. Another test they looked at was impaired reflexes. Right, so let's see how accurate our assessment of reflexes are. They looked at the patellar tendon and the Achilles tendon, and that was examined by 7 studies. Generally, they didn't produce favorable results. The specificity ranged quite a bit. It did range up as high as 0.93, but the lower ends were about 0.6. And again, this is really due to just the poor quality of the studies involved. They did find, again, in that primary care population, they had a much higher specificity in that study. So low sensitivity, higher specificity in the primary care population for reflexes. Again, if you're finding someone and you're looking to rule in a herniated disc or a nerve root compression, if they have impaired reflexes that are going to go along with the level that you're concerned with, at least in the primary care study, it was found to have good specificity. So a positive test there might be significant to you. Another test they look at was the presence of sensory deficits, right? So you have some sort of paresthesia, tingling, maybe even a hyperalgesia, That was looked at by 6 studies. Again, diagnostic utility as a standalone test was pretty low, except the same thing happened in that primary care study. It was found to have good specificity. So if that person had some paresthesias, especially along the dermatome of question, that was found to be a valuable test in primary care. They looked at forward flexion and hyperextension. So, when you're doing your general range of motion testing, even like in the McKenzie method, that kind of stuff, you're looking to see if there's centralization or peripheralization, but they actually looked at it to see if just the presence of pain was a valuable test. Flexion was studied by 3 of the included articles, showed conflicting results. 2 studies with the surgical population found that a positive forward flexion test to be highly sensitive. So they were looking to see, that had a high rate of true negatives. And the 3rd article, using the primary care population, showed the opposite, actually, right? So that was kind of a toss-up. All 3 studies used completely different methods. And again, we'll talk a little bit more about that when it comes to combinations of tests. The hyperextension test was also looked at by 2 of the studies, also had conflicting results. Same kind of thing as the flexion tests. Dave, I think that actually comes back to an earlier talk we had in a different episode about, I think the diagnostic value of these tests, especially something like forward flexion extension, becomes infinitely more valuable when you can talk about the location of the pain.
Right, exactly. Because, in lumbar disc herniation, you would, I guess expect there to be more specific area of pain as opposed to just your non-specific low back pain. I don't know if this is more for like SI joint stuff, but you have the Fort and Finger test.
Yep.
Where, you literally say to the patient, point to your pain. And we did discuss this in a previous episode, but it does make the evaluation process much easier when they could really point to that spot. Definitely.
Yeah, and actually the next test they talk about was the Slump Test. Yep. And it was only evaluated by 2 studies. And they both use different procedures, which again is going to make generalizability tough. But they talked about it depended the diagnostics of how valuable that test were depended on whether or not they just had a positive test being pain anywhere or pain below the knee. Again, to me, I think it's more valuable to reproduce pain that's familiar to the patient, right? So
right.
is that reducing your pain?
Yeah, and that's a big follow-up question I like to ask a lot of patients too is, we do something and they're like, oh, that hurts. And then you say, okay, well, is that the pain that you're used to, or is this a new pain, right? Because then, what exactly are we getting? You might as well have a negative test then if it's a pain that they've never had before and it's a new pain. So right. Yeah, definitely getting that piece of information just adds to the whole puzzle.
For sure. So what they actually found for the slump, that when the pain was just when the positive test was just pain below the knee, the sensitivity and specificity were both pretty low. But when they opened up to pain anywhere, again, which I don't know if that's the perfect way to do it, but pain anywhere, the sensitivity increased. So they were finding that when you ask for pain anywhere during a slump test, which if you're not familiar, a slump test, you're having the patient seated with forward flexion of the trunk and kind of just big rounded kyphosis, let the head flex, and then you're going to basically extend the patient's knee out and then add a little ankle dorsiflexion in. So you're trying to maximally stress that neural tissue. So when they found that produced pain anywhere, they had a little bit higher sensitivity. So they were finding that a negative test result there was valuable. The last one they looked at was the Bell test, which, again, I just never really called it this, but it's just basically giving P to A pressure at the spinous process of either L4-5, well, I guess the inner space of L4-5 or L5-S1. They found poor diagnostic utility for that test as a standalone. But again, I think it is something valuable in combination, because that's something where if I'm looking to rule the lumbar spine in as a source of pain, if I'm doing central pressures and it's reproducing leg pain, that's going to be some valuable information to me. But so again, getting into that, the end of the study talks about combinations of tests. And obviously, as it is with most other diagnosis, it's a little bit higher specificity and sensitivity when you combine tests. One study showed that there was a high specificity with a positive cross-straight leg raise combined with a positive Bell, hyperextension, or straight leg raise test. So they're saying that if you have a positive cross-straight leg raise and you're either able to combine that with pain on central pressures to the lumbar spine, with pain with hyperextension, or with a positive straight leg raise test on the affected side, that was shown to have high specificity, 0.74 to 0.94. Those are pooled estimates, and again, they didn't report any likelihood ratios in the Cochrane review, just because when they were pooling estimates for sensitivity and specificity, there was such a large amount of heterogeneity that they had a hard time pulling out likelihood ratios there. But the primary care study found that the following combination showed to have the highest association with nerve root compression on MRI. And this was age, duration of symptoms 15 to 30 days, paroxysmal pain, so the pain comes and goes, pain worse in the leg than in the back, typical dermatomal distribution of pain, right? So that the level that's in question there is corresponding where they're having a typical dermatomal distribution of pain. The pain is worse with coughing, sneezing, or straining. Finger to floor distance during a forward flexion test, right? So how far they can bend over, and paresis of a muscle group. Again, with all those things combined, having positive tests that are corresponding to a certain level, that's what they kind of advise were the best history things to put together to have a diagnosis of herniated disc with nerve root compression. So that's the end of the Cochrane review. I just want to touch quickly on that was 2010, so I did look to see if there's any newer reviews.
Nice.
And there was a systematic review done in 2017. Dave, we were talking about likelihood ratios before. This one actually did give you some likelihood ratios. So that's again making you feel a little bit more comfortable with these tests. And so the review in 2017, it's called Clinical Classification in Low Back Pain, Best Evidence Diagnostic Rules Based on Systematic Reviews. And this was published in BMC Musculoskeletal Disorders. They did publish some likelihood ratios, and it actually varied based on the nerve root level. L5 nerve root positive likelihood ratio was 2.2, which is a little bit lower, but L4 and S1 were 5 and 4.7 respectively. So those are pretty respectable likelihood ratios there. And again, so what the test cluster was that they used there, it was a positive straight leg raise test combined with at least 3 out of the 4 of these following tests. dermatomal pain, sensory deficits, abnormal reflexes, or motor weakness, right? So if you had a positive straight leg raise and you had either 3 of the 4 of dermatomal pain, sensory deficits, reflex, or motor weakness, you can be pretty sure that you're dealing with a herniated disc with nerve root compression. They also advised that using the cross straight leg raise test, due to its high likelihood ratios and the value of a negative straight leg raise test, that's what they basically advised to roll things in and out. Sorry, that part was kind of confusing. The cross straight leg raise test, due to its high positive likelihood ratios, should absolutely be used when diagnosing. And on the contrary, a negative straight leg raise test when you're looking to rule out nerve root compression. So that was a big old mouthful, but that's how Cochrane Review is, right? There's a lot of information in those. I tried to pull out the most valuable things for you.
Perfect. Thank you, Corey. Yeah, I mean, that's an all-encompassing, comprehensive review there of some examination eval techniques for disc herniation. I like it. So going into my article now, the article I chose to review comes from the Pain Physician Journal in 2017, titled Incidence of Spontaneous Resorption of Lumbar Disc Herniation, a meta-analysis. It comes from a group of physicians at the Shanghai University Department of Orthopedic Surgery in China. The article starts with an introduction stating there is little difference between patients with lumbar disc herniation after 2 to 5 years of receiving either surgery or conservative care, as well as studies showing that with conservative care, there is resorption of the herniated disc from both MRI and CT scan. So that is with intervention, right? So what this meta-analysis wanted to look at was the incidence or frequency of spontaneous resorption of the lumbar disc herniation without doing anything. Just does it go back in? So usually in experimental research, we try not to get too bogged down on the exact methods of the study, especially in this sort of format, and we try to pull the important information and speak about that. So kind of like what Corey was saying before, there's a lot of methodological things that are in these big research studies, but again, we try to pull them for you, and then we leave the references. If you have questions or anything like that, feel free to let us know. We could look into it for you, or you have the opportunity to check it out yourself. So, but since this is a meta-analysis, I believe it's important to go over some of the criteria that the authors use to select the studies, because it is such a big study. So we're just going to go over it quite a little briefly. The authors started searching for articles in December 2015. They went all the way back to 1999. So 99 to 2015, pretty big span. Conservative treatment was utilized. An MRI or CT scan was used to measure the size of the lumbar disc protrusion. The primary tool the authors used to assess the quality of the included studies was the QUADIS 2. It's also known as the Quality Assessment of Diagnostic Accuracy Studies tool. It's a way to really generalize each study to make sure that they're all sort of hitting on the right points, right? To really check the level of these studies, see how strong they are. The information gathered from the studies included the country, which will come into importance later on. So the country, the age of the patient, the length of the follow-up, the method of imaging, the number of lumbar disc herniations, and the number of lumbar disc herniation patients with spontaneous resorption, according to MRI. There were 11 studies that were included in this quantitative synthesis to produce the meta-analysis. So, what did it show? The results showed that the overall incidence or frequency of spontaneous resorption after lumbar disc herniation was 66%, with a 95% confidence interval of 55 to 78%. Meaning that if you take 95% of individuals, you grab 95% of people with lumbar disc herniation, they would have a 55 to 78% likelihood of resorption of that lumbar disc herniation. So
those are good numbers.
Those are good numbers. Those are good numbers. Here's the really interesting part, though, which sort of goes into a different level of thinking. An interesting finding was that all these articles from meta-analysis came from a bunch of different countries, and they found that in studies from Japan, the average lumbar disc herniation resorption was about 64%, so very close to that 66% for the overall. In Japan, it was 64%, but in the United Kingdom, the resorption rate was close to 82%. So this brings us into questions about medical standards. You could even talk about daily habits, activities, all different things. It's a lot to talk about, and more research needs to be done. This is a pretty new study from 2017, so maybe there's something going on in the works. We'll have to check back on that. But it's interesting, Yeah,
that's a great point because, right off the top of my head, I start to think when someone in those countries presents with low back pain, with radicular pain, what does their standard of care look like? You know what I mean? What does their course of care look like?
Right.
That would be interesting.
Yeah, and I think, it's very interesting. I don't know really anything about Japanese culture. Heck, I don't even really know much about the United Kingdom culture or healthcare system. But those are two pretty stark differences.
Yeah.
And, all these studies were assessed reliably. So, these weren't terrible studies. So it's, I don't know, something interesting. It's a head scratcher there. So, one of the limitations, though, of this meta-analysis that I should talk about and discuss is that there were no randomized controlled trials that met the criteria for inclusion. So, whether that means that these authors put a really high level of criteria for the inclusion, or if the articles were just kind of not really at that level, this sort of comes into question with some of the results of this meta-analysis, but nonetheless, it is a meta-analysis. So, I guess if the bricks that build the house are kind of crappy, then the house itself is going to be a little bit crappy. But you got to take it for what it's worth. The study looked like they were pretty thorough. They did the best they could. I think what it really means is that we just need to know more. Just need to continue to build on all this information. So the major take-home point from this article that I would say is that a trial of conservative treatment should be employed first due to the potential for spontaneous resorption as well as a decrease in economic stress to the healthcare system. Now, I didn't bring this up to Corey beforehand, but I have a little side note that I want to jot down. After reading this, I became very interested in the healthcare expenditures in the United States of America, where we live. And I did a little looking up and looked at some numbers, and I just want to throw some numbers out there for you, okay? So we talk about direct access, we talk about seeing a PT, we talk about how we can help these people. Let's just sort of look at some of the expenditures that are going on. Corey and I are kind of like business people. We like talking about numbers, so let's just break it down real quick. So this comes from CMS.gov, Centers for Medicare and Medicaid Services. This is the National Health Expenditures of 2016. So this is pretty recent. Usually when you get information like this, it's usually 3 or 4 years behind because it just takes so long to pool all the data, get all the information, all that kind of stuff. So the U.S. healthcare spending increased 4.3% in 2016 to reach $3.3 trillion, or $10,348 per person in 2016. Per person. I don't know about you, Corey, but I don't really think I spent a penny
Right.
I'd really spent very little in healthcare in 2016, or really throughout my entire life. I've been lucky in some senses, but in other ways, I haven't really used too much, which is okay. I understand other people, they need healthcare services. But
and of course, the percentage of people who are over 65 at this point,
this is
who
true.
will require more medical care, is that number is very large.
Mm-hmm. Yeah, it's very interesting, and it goes on to say, so the big thing that it really mentions is it talks about GDP, gross domestic product, which usually in countries is a big indicator of the overall health of the country, right? It's kind of like a big measure to look at. So we won't go in too much to it, but healthcare was or is one of the biggest things that we spend in this country. Almost essentially 18% in 2016, which was up from 17.7% in 2015. So it may not seem a lot, but again, we're just growing this healthcare thing. It's absolutely wild. Prescription drugs, talk about prescription drugs. The growth in retail prescription drug spending slowed in 2016. It slowed a little bit, so okay, not too bad. It still increased, though, 1.3%, to bringing it to a $328 billion industry, prescription drugs. Prescription drugs, $328 billion. So it's something that we really need to look at.
And to piggyback off of that, Dave, you know how much a spinal fusion costs? Which is what some of these folks who maybe who are, let's say, preemptively pushed into surgery might end up with. I mean, I would say a conservative estimate is over $100,000.
Yeah.
For sure.
Yep. Maybe one episode we'll just break down some business stuff. But this is something I just really wanted to bring to attention.
Totally.
It's pretty staggering, these numbers. Especially you look at studies that I had mentioned here where, 66% of people, their lumbar disc herniation reabsorbs.
Right.
It goes back in.
Yeah.
So obviously you have to look at other symptoms and, other, functional type things, but, it heals itself. The body heals itself. We're very quick to jump in and do surgery or do treatment, get drugs, right? But there's other ways to do it. So I think
it could be cultural differences too. But actually, so getting back, maybe preemptively towards the patient case, one of the things I actually find that starts to really influence what happens with a patient and how quickly they might heal or how quickly they might tolerate what I'm doing. Weirdly enough, and I think there's some evidence for this, I don't know that there's a ton, but their work situation.
Yeah.
I find that people who are in a workers' comp system tend to, I will say they tend to be pushed through the system a little bit faster because, of course, it's about money at the end of the day.
Right. Mm-hmm.
Their work doesn't want to lose any more money.
Correct. Yep. And understandable. It is a little bit of anecdotal.
It is, yeah.
But it's. I think that's a valid point. I would have to agree with you as well. I'm sure there is some sort of research out there that breaks it down, but it seems to be the case. And again, like you said, going back to this patient case, 38-year-old male, sits down. Gets all these symptoms, works constantly at his desk in that terrible posture. And then again, this is, we talk about psychosocial factors. It all sort of just plays into itself. It's all wrapped into one. So what, from your article, Corey, what would you look at with this guy? Give me some key things to really gain from it during your evaluation.
Yeah, certainly. So I'll kind of brush over some of the history things because I think that's where you're going to get the meat of it. You're looking to see when specifically is this guy getting symptoms. If it's with sitting, great. He has some trouble with flexion, or at least let's just say with sitting. How does he do in extension? How does he do if you get him standing in extension? How does he do if he is prone in extension? They brought up good points about the history as far as pain is worse with coughing, sneezing, or straining, right? That's going to increase our intradiscal pressure. And if he has a significant herniation, that might make those symptoms worse. That might give him that shot right down the leg. And again, when you're talking about a nerve root issue and a symptomatic herniated disc, I really think you should be able to correlate this to a specific level. And that should all add up with all of your physical tests and history. What's this guy got going on? Is it all down the posterior thigh and into the calf? Maybe you're starting to look at L5S1 or S1S2 as a symptomatic level. And then you can start to correlate that with your reflex testing, your manual muscle testing. As far as the physical tests go, they are better done in combination, right? So that's why I'm kind of getting to this, is there's a lot of different stuff to look at. Some of the best things I think to look at based on what I reviewed in the research here is the straight leg raise test. And again, that being a highly sensitive test. So if you think someone's got a right-sided nerve root compression problem, they test negative in the straight leg raise test, and they're not adding up on any of your other symptoms, I would start to look at other causes for that pain. On the contrary, the cross straight leg raise test, which is the straight leg test done on the asymptomatic side, if that's a positive test, then you're starting to rule in that lumbar disc herniation. And again, with those two tests, it's got to be all combined with your neurological testing. I think making your exam more efficient and more organized is an important thing for all of us, because no one wants to take that patient who's in a lot of pain and roll them through a 40-minute eval, and half of the stuff is probably not useful or relevant. And you've had him up and down and on his side, and he's starting to get really aggravated. But I think the straight leg raise, the cross straight leg raise test, combined with your neurological testing, is going to give you a good picture of what's going on. Some things, again, probably more anecdotally, that I like to add in. I like to do a really good, especially when I'm questioning the location of the pain or the source of the pain, I like to do a really good thorough exam on the lumbar spine regarding central pressures, right? I want to kind of drive in on that, folks, and see if that's reproducing some of his symptoms, because it really should start to add up.
You said,
and again, I think that's even more valuable when you're starting to question, I don't know, is this a hip thing? Is this a low back thing? Is it a referred pain thing? I think combining all these tests, you shouldn't have a question on most patients.
And you said that was the Bell test?
Yeah, they called it the Bell test, which they described as just pressure to the spinous process.
Oh, okay.
Yep.
Very nice. Very nice. Good. Well, all right. Well, that's a pretty good summary right there. Lumbar disc herniation.
What would you say is the pullout from yours, Dave? Because I want to add to what you quickly said about your article before you give me that take home. There's another article, I don't know if you ever saw it, and it talks about basically the probability of resorption based on the different levels of herniation. So whether it's sequestration or herniation or a bulge or a protrusion.
Right. Yep. I did not. No. I did not hear about it.
So again, I know I just wanted to add this in as a different flavor, but this was 2015 Clinical Rehabilitation by Chu et al.
Nice.
And basically, I mean, I would say the N values are, not terribly high, around 100 or so. But they actually found that for the worse the herniation, right? So the disc sequestration being the worst, where that material has extruded out of the tear, and it's now almost not in contact with the rest of it.
Yeah, it's all broken up. Yep.
96% spontaneous regression.
Look at that.
Those are good numbers. 70% for disc, 70% for extrusion, 41% for protrusion, and 13% for disc bulging.
Interesting.
So, I mean, again, going along with probably what your take-homes will be, is these folks have a pretty good prognosis.
There is, yes. And I think that is probably my main take-home, is that people presenting with this sort of disc herniated low back pain, they need to be constantly educated to know that there is a very good likelihood that everything will get better, and they will feel better. There, of course, are those outliers where, things continue to progress, and, there's other interventions that are required, but for a good majority of people, things will get better, especially if they are taught to move correctly, and you hit a lot of the major impairments that they have. So that's a good little adjunct to my article. Thank you, appreciate it. But yeah, that pretty much wraps up lumbar disc herniation. We appreciate everyone listening. We hope you are continuing to gain some knowledge, some content from this. If anyone has any questions, any comments, if you like it, let us know. We appreciate any feedback. And I would like to say have a great night, everyone. We'll catch you next time for the next episode of PT Forensics.